I'm going to make a start, and I'm sure we'll get more colleagues joining us in the next few moments as they're able to join. So welcome everyone to this webinar about valproate and topiramate safety. Just a few housekeeping rules there that we've put up on the first slide. Just please remember to keep your microphones off unless you're invited to discuss a question later on in the webinar. Where's the next slide, please, Janice? Thank you. So just by way of an introduction, my name's Minu Paul. I'm a GP. I work in Oxford. I'm also the clinical lead for medicines, and I work closely with the medicines optimization team at the ICB and also with the pharmacists and consultants that work across the trusts in our area of the ICB. And really this webinar came up as a result of some discussions that we'd had with a number of colleagues in recent months, and particularly around a pharmacist conference that we held a few weeks ago, where we had PCN pharmacists and practice pharmacists attending, where they wanted more clarification and more information about valproate and topiramate and the regulations, the MHRA alerts, and actually how this might work practically for you within your own practices. And we've also been getting a lot of queries coming through from the medicines optimization inbox around, again, just concerns about wanting to know a bit more information. And so we were asked to actually put this webinar together. So we've got some good speakers coming up later on in the webinar. Janice from the medicines optimization team is going to run through some resources that we've actually got on the ICB medicines and formulary pages for you, and also some national resources. We've then got Sarah, who's a senior clinical improvement manager from NHS England, who's been working on improving valproate safety across the southeast. We've got Jane Hannah, who's coming to speak to us particularly around patients' perspective, and then we've got some case examples with discussion from Dr. Jane Adcock and Orla MacDonald, who work in the trust. So Jane works as consultant neurologist at OUH, and Orla works as a lead pharmacist at Oxford Health. And then we've got some time at the end for some Q&As. So please do pop your questions in the chat box, and we'll endeavour to answer as many of them as we can as we go along. And then perhaps if we need further discussion, sort of open discussion at the end, we can open up some time for that as well. Can I have the next slide, please, Janice? Thank you. So just as way of background, just to say that in January 2021, the MHRA completed their major safety reviews on anti-epileptic drugs and their safety profile, especially during pregnancy. And the conclusions that they came to as a result of this review were around physical birth abnormalities in patients that were taking these anti-epileptic drugs. And you can see the rates there of abnormalities. So in the general population, 2 to 3 out of 100 babies. And then at the bottom, we've got topiramate, 4 to 5 out of 100 babies, and then valproate, about 10 out of 100 babies. This improvement in the safety aspect of valproate is part of the National Patient Safety Strategy for the NHS, and is part of our medicines optimization opportunities for England. So there is a real, as well as the MHRA, obviously having their recommendations, there's a real sort of national steer from NHS England about getting this right as well for patients. Can I go on to the next slide, please? So it's quite a complex slide, but this basically just gives you a bit of information about the timelines for the regulations and how things have evolved. In 2018, the MHRA released a drug safety alert around valproate, saying that it was contraindicated in females with childbearing potential unless there was a pregnancy prevention programme in place. And then in 2022, there was further communication from the MHRA with further reminders, and to say that also there was going to be upcoming further safety measures that were going to be put into place. In 2023, there was a reanalysis on the risk to men, and later that year, we were told that valproate must only be given in full packs, so we mustn't break packs. And I think the reason behind that was to ensure that the safety messaging and the patient information leaflets were included in the full packs, and that patients were getting that information. And then later that year, there was a national patient safety alert to all organisations in the NHS around the safety aspects of valproate. Coming on to this year, again, the MHRA strengthened their advice, and new regulations came into force. Further CAS alerts went out to all the trusts and the chief medical officers about valproate. And then in June, we had further alerts around topiramate, new safety measures, and the pregnancy prevention programme. And in September of this year, we had further advice regarding men for valproate. So this sort of journey to where we are now has been going on for 6 years. And in the last 6 years, we've had sort of strengthening of the regulations and the expectations from us in primary care and secondary care around prescribing. And so we're going to go through now what those regulations are and where you can access information around these. Janice, I'm going to hand over to you now, please.
Thanks, Nino. So I'm not going to go through these in detail, but I think they're a really good summary of where we are in terms of regulatory position. So this is one for valproate, and because they've been coming out in bits, I think it has been quite confusing as to where we're up to in terms of ARAF, RAF, who needs it done when. Do you need it just once, or do you need it ongoing? So we will be going through more of this in detail later, and we will share the slides after. So that's one for valproate. So this was the CAS alert that Mina mentioned, was out last year in November, and that went through the safety issues, actions required, I guess relating to primary care as to what was being expected. It was the continuing support to patients with that as needed, and providing advice where it was coming out from. CQC may seek assurance from all providers that these plans and new measures are being implemented, because there are MHRA safety regulations that are now in force. And I think even before this came out, valproate was one of the kind of clinical searches that CQC might come in and ask about at practice when they're doing their visits. But I think one of the key things that we do want to highlight is that no one should start taking valproate without advice from healthcare professionals, because that is absolutely key, because obviously that could destabilise someone's clinical condition there. We have, so as part of that, there was a request and the responsibility from the systems, and it's led by the ICB quality team from that, the CAS alert. Following on that, from December of 2023, we set up a task and finish group, where we've got our system key stakeholders and partners that we work with. So our mental health trusts, our acute trusts, we've got primary care, we've got community pharmacy colleagues, we've brought in our sexual health clinic services, we've got a patient representative, so that's SUDEP that you'll hear Jane speaking to later. We're working with Sarah, who's on today as well, from our NHS England South East team. So it's been a real system approach, and we have been working very hard behind the kind of scenes to really kind of delve into this. I think first things first was the process of identifying who are our patients, where are they, how many do we have, because there's not a central or even I guess a local register of all patients. It's been a significant impact in terms of actually how this is going to impact on our secondary care clinics and also primary care, and in terms of admin time, as well as the kind of patient conversations that you need to have. We need to make sure that our patients are still getting the right treatment, because it is not a a kind of mandate to stop prescribing valproate. Valproate is still going to continue to be registered, and for some patients it is the right and potentially only clinical treatment that is going to kind of control their condition. So it's very important to make sure that they still have access to that. And as we know that there are a lot of patient concerns, that actually the concerns that they're not going to be able to have access to medication to control their symptoms anymore, their clinical conditions. And obviously any changes in therapy could destabilise and have a significant impact on patients and carers' quality of life. So that's all kind of things that are kind of being considered. All the organisations are continuing to look at their services, but there are significant impacts that during this we keep on finding, and we do working very hard with our kind of partners to help them through this. We are escalating through our NHS England colleagues back up to national and and the MHRA as well, that the impact that this is having, because unfortunately it does have a knock-on effect in all parts. So just as a start, we looked at our primary care prescribing data to work out how many patients could potentially be affected and that would need to be reviewed. So valproate we looked at right at the beginning of this year. So and this looking at the different areas. So in all there was at that time, and this is primary care prescribing data just off EMIS, but there's some who are we've got some practices who don't use EMIS, so there's some from there as well. We've got over 4,000 patients on valproate, and actually if you split that into we split it into the females on the age range, and then actually now if we expand that out to all males of any age, we've got a significant number more of male patients, where that is going to need to be reviewed at some point in the system. So in terms of topiramate, obviously the new safety regulations came into place for that as well. So I guess for primary care, it's the significant impact will be those females and having coded as having a migraine, where the ARAS may need to be done at some point as well. So not as many as valproate, but still a significant number. And obviously then there are patients who may be having that for and are under neurology care. So again, that impacts on the above in terms of valproate numbers of patients. So what have we done so far locally? Hopefully you're already aware of this, but if not, we have a new the group got together and we have a Bob oral valproate share care protocol for all patients, male and females, under age of 55 and those over 55 who are planning to have children. So it's linked on all three of the individual formulary areas. We've looked into things like roles and responsibilities, what are the ongoing monitoring requirements, and it does include all the specialist contact information as well, because I think there were a number of questions saying how do we contact the teams. That is on the share care protocol. As part of that as well, we did put in a kind of best practice pathway for patients within Bob who are prescribed valproate. So I would encourage everyone to have a look through that in the share care protocol. We have also produced a memoir, and this is for valproate on EMIS and System 1. So it links to where you might find a clinical search to help identify patients who may need reviewing. In there, we've got information about clinical templates like ARDENS that you might be able to, that you could use, and codes as well, clinical SNOMED codes to put onto the records, which might help with the management of these patients. And like I said, we've been working with NHS England colleagues as well on safe prescribing, and Sarah's going to touch on some of this, but it does include translated easy read leaflets as well. So I'm not going to go through this in details, but in terms of where to find things, the risk materials are on the on the EMC websites for valproates, and those are the kind of leaflets that are on there. that was if you link back, the MHRA drug safety updates give very clear advice on what for healthcare professionals and also what to provide for patients. That was the September update. In terms of the further information about valproate use in men, MHRA have produced some leaflets as well, visual diagrams that could be used. But as a group, we did look at these, and they don't provide a kind of baseline risk. So that's something to consider, because it only looks at valproate and lamotrigine and levetiracetam in there as kind of baseline figures. But I think one of the most important things that we'll keep on reiterating is that patients don't stop taking the valproate or topiramate or altering their doses unless they're advised, because obviously their condition may get worse. And lastly, NHS England have a programme on the NHS Futures website. There's a specific one on valproate, where there's lots and lots of resources in there. It links to the NHS England decision support tools as well. There is an example of how general practices might respond to the paternal valproate risk. So this is a flow diagram that someone, that's another area, has uploaded. So it's worth having a look at those. And that was just where it is in terms of topiramate and the regulatory position and the risk materials that are on that are available for those. So I'm going to hand over now.
Thank you. Thanks, Janice. I think there's a lot of sort of information there to digest, isn't there? And I think one of the things I would urge all of you to do is actually just have a little look at the shared care protocol that's on your individual formulary. So Bucks, Berkshire, Western, Oxfordshire, because the valproate one's just been updated with all the paternal risk information as well, and it gives very clear guidance as to what you need to do in general practice around the monitoring and the annual reviews and the ARAFs and so on. So do take a look at those. I'm going to hand over to Sarah Fishburn, who's going to give us the national NHSE update on this. Thank you, Sarah.
Thank you very much, and thank you for inviting me to join you this afternoon. I'm just going to follow on from quite a lot of what Janice has been saying and talk about what we've been doing at a regional and national level. So I work in the South East regional team, in the quality improvement team, and what we've been trying to work up is a regional approach to improve safe and person-centred care. So making sure that the patient is able to make an informed and supported decision about their care. And there has been some tension between the MHRA safety alert, which focuses on potential fetal defects during pregnancy, and women's healthcare needs with epilepsy or mental health conditions, and trying to balance those alongside the NHS principles of shared decision making and person-centred care. So what we've been trying to do with our approach is balance these different aspects and supporting regional clinicians' needs, because we've been hearing that from clinicians that there are capacity issues, and so we're currently collating data on delays in neurology and mental health services, which may be related to the additional workload that's being generated by the extra checking required, and trying to assess the impact on the wider population of the new regulations. So we've been doing that by engaging with clinicians and service users and providers of care services across the region. We've also been engaging with MHRA to raise their awareness of the issues that are being encountered in practice, so particularly in secondary care, where the impact of the second checker is having a huge effect on the number of clinics available and on clinicians' time. It's very complex because MHRA don't actually regulate the NHS, so they look only at drug safety issues. So they're focusing on the impact on an unborn baby. So they're not looking at the wider safety impact on the woman's health or the wider system, and their response is that this is for the NHS to address. So we have that that complexity to address. So the other thing we've been looking at is we've developed a logic model to try and unpick all the different aspects of the program required to implement second checking and to implement a safe system for making sure that women are making really informed decisions about taking valproate or not taking valproate, and that is their decision rather than being an enforced one. So we've had input from ICBs, providers, care organisations, charities, and individual experts by experience, so people with epilepsy and learning disabilities who we've met in person. We've had an initial meeting to develop a logic model, first in person, and then we've had 2 follow-up webinars to try and do that. And we've shared the output from that, and then we're putting together a business case which will be hopefully will be useful to ICBs and trusts when they're looking at how to fund their or how to put together a bid for any additional resource. We've been making some progress with the digital solution, because that's one of the things that clinicians have said is needed, and there isn't a national digital solution proposed. So we managed to get together some regional funding to develop a prototype, so a pilot. And OUH is going to be one of the trusts that's going to be piloting that, and then there are 2 trusts in Surrey. So that's great, because that means we can actually move forward and work on something that could work and be rolled out more widely if funding became available. So if we can get a kind of proof of concept. So the idea of this is that it'll set up a register of everyone on valproate and a recall system, and then there'll be a digital form, so it can be completed by the patient and the specialist together. And so to develop it, we've ascertained what the clinicians and service users need from this. It's tricky because everybody needs something slightly different, so it is trying to, the thing that will work for the most people is what we're working towards. And we've now got an outline plan or template which is being reviewed with IG teams and clinicians. It's still a work in progress, but and we need a consensus to be able to take it forward. And it can be tricky because we often have different people in the room with different views each time, but we're making steady progress and keep moving that forward. And we're working on the IG requirements between the ICBs, the trusts, the region, primary care, and the developer. As Janice mentioned, we're also developing an easy read booklet. So we started that with mainly clinician input with some service users and community care providers. And we've had a couple of iterations of that. The second iteration, we've got over 100 comments. So I made all those amendments, and then got the final version was reviewed by service users and charities for people with learning disability and epilepsy. So they're going to be the end users of this leaflet. So it's absolutely crucial that they had the final say. And we're on final amends now at this stage. And once we've got those final amends agreed, we'll then translate it into the 30 most common languages across the Southeast. So that will hopefully make it more accessible, and it will be available through a QR code on the leaflet and a landing page, which will be linked from the booklet, or can be added to any information that you're using at a local level. So that's where we are at the moment. I'm very happy to answer any questions or give more detail. Oh, I can't hear you, Minu, sorry.
Oh, sorry, Sarah, thank you. I've just noticed in the chat we've got some questions, particularly around the shared care agreements and also the pregnancy prevention programme, and we'll answer those in just a moment. But any questions in relation to Sarah's presentation? Anyone particularly want to ask anything directly to Sarah? I think what was really interesting, Sarah, is that when we did the sort of flow chart of how things work now and where we need to get to and what the problems are in between, there were lots of things that came up that we hadn't considered as issues. And I mean, as you said, one of the biggest one is capacity issues, both in secondary care and primary care. And actually, how do we enable both of those to actually be able to deliver this in a way that's actually effective, but also not time consuming in terms of sort of paperwork and admin and so on. And I think it'll be interesting if this digital model does become if it does help and it is useful, we can get an update on that in time, and to see if that will be useful for everybody.
Thank you.
Okay. Yeah, thank you very much, Sarah. I'm going to move on to ask Jane if she would give her presentation. Jane, are you there? Yeah, brilliant.
Yes,
Thank you, Jane.
Yeah,
Thanks.
thank you very much for inviting me. I mean, in terms of, I suppose, my credibility to sort of bring this perspective, I've been involved, I've got lived experience of epilepsy, and I've been involved for 30 years, sort of working with specialists, general practice, researchers, patients, families. And last year, I led an epilepsy coalition of 11 medical charities and patient charities who were opposed to the introduction of these accelerated measures because we felt they were unbalanced and unsafe, and we also felt that the pressure on the system, on the NHS right now, without any additional resources, would worsen waiting lists and worsen patient safety and clinical welfare. I'm involved in Embrace. I'm involved maternity surveillance leader. I was on the steering group of the last National Confidential Inquiry into Accident and Emergency for people with epilepsy, and I led the last NICE audit into epilepsy mortality alongside 5 medical colleges. Next slide, please. So I founded SUDEP Action, and this is our team. We're made up of clinicians, researchers, but above all, 50% of people with lived experience. We specialise in risk in epilepsy, and over the decades, we've not only identified the problem, but we've brought solutions, which I'd like to share with you quickly now. Next slide. This is why we exist. These are just some of the more than 21 deaths a week from epilepsy. The sudden deaths normally happen in young people. So this is a pretty representative slide of what can happen if when people die because they haven't accessed care and treatment. Obviously, not all deaths are avoidable, but a very large number are from the evidence we have across the UK. Next slide. There was a lot of progress 2 decades ago after the national audit, but in 2013, one of the biggest improvements, which was introduced in an annual review in primary care, was cut away without consultation. To build a lifeline for people out in the community where knowledge of epilepsy and risk is inevitably extremely low. We researched and developed since 2010 with research teams across the UK a digital tool which is known as Epsimon, and it's a tool which a patient can have. And it brings expertise to their fingertips in relation to epilepsy risks that they might face across seizure control, but also in relation to their mental health, and suggests that this can be part of their conversation with health professionals. It was recommended by NHS Right Care in 2020, and it's come up as recommended in numerous coronial prevention of death reports, including one this year where the Royal College of General Practitioners responded in a letter sort of following a sudden death. So I would suggest that this is a really useful app, and we had people with lived experience just saying this is something actually that is really helpful to them. So just signposting to the app as part of any conversation will be helping to balance any conversations that you're having in relation to access to medications. Next slide. It's a digital version of a clinical tool called the Pseudoepilepsy and Seizure Safety Checklist, which was developed after 2010 and was proved to reduce risk across multiple settings in the southwest of England, and sudden deaths dropped. It's also a very helpful tool really for checking really that there is informed consent and shared decision making, particularly around any kind of conversation which may involve the removal of a life-saving medication. Since the pandemic, it's actually been integrated into 80% of GP software packages, and it's been adopted by several NHS trusts. So it is actually in general practice software. You know, if you're having conversations anyway, then this is a tool that takes 10 minutes alongside that conversation about the risks of side effects of medications. So I would recommend that it's a useful thing to use, and as I say, it is available to you. It's also been used in other settings, not just general practice. So you know, pharmacists, so any generalists in settings can actually make use of these tools. Next slide, sorry. All our resources are developed in co-production. These are particular resources for people with learning disability who are especially vulnerable. And they're easy read resources, videos, but also we have a checklist for commissioners and providers of residential care that was commissioned by the NHS Midlands region. These are checking tools again, which can be really helpful for anybody who's working in that field. Next slide. So valproate. You know, valproate, clearly, we all know the high tetragenic potential with 11% risk of congenital malformations and that 30–40% of risk of neurodevelopmental disorders if it's taken during pregnancy. But what isn't so well known, unfortunately, is that it is also the most potent cost-effective medicine for cliff edge generalized epilepsies. So there's a series of articles there. But you know, the SANAD clinical trials are very clear. It is the most effective medication. And clearly, if you remove somebody from the most effective medication who has the most dangerous types of epilepsies, then that can be very dangerous for a patient. Obviously, in terms of wider risks, a study this year, a large study showed that the risk of A&E, hospital admission, injuries, burns, and onset depression was 1 to 7% higher for patients taken off valproate. The boys and men's evidentiary threshold for regulatory action is heavily contested. There's a really important Denmark study with over 1 million children, which has published to say no association found between use and risk of major congenital malformations. So that can be very reassuring when talking to boys and men about the benefits of valproate versus the risks of valproate to them. The likelihood is they will not be aware of their risks of epilepsy. So they will be flying dark. So it's going to be really important they have that balanced conversation. It's not just about death. You know, men and boys, they will need to know that they can lose their driving licenses if they have breakthrough seizures. That is probably going to be one of the most dramatic impacts in terms of quality of life for patients. In terms of the evidence around the worst outcome, these sudden deaths in the young, 69% of these deaths in people with generalized epilepsies can be prevented if they're supported to be seizure-free. So the 2024 accelerations requiring 2 signatures are very extreme measures, which have not had public consultation and are not adopted anywhere else in the world, and are causing patient harm. There's a thematic review there that's been done with patients and families harmed by the pregnancy prevention programme. And that's on top really of the evidence from Embrace maternal deaths, that there's been a near doubling of deaths known in women during pregnancy and their unborn, against the context of the prevention programme. It's really important, I think, for clinicians to know that the MHRA has made public statements that no one who needs valproate will be denied it. And that has been said at a national level. And it's really important in protecting any clinicians who are keeping patients at the centre that these are statements that have been made by the MHRA. Next slide. I know I'm really running out of time now. Sorry. This is just a slide, maybe just to reflect on after this session. This is a real case, and strangely, I mean, unusually, it's the GP here really who has taken on the prescription of valproate. And they did that for a very particular reason in terms of their understandings of the impacts of the programme, and probably quite unusual that I think this is quite an extreme approach that was taken by a particular hospital trust, but it had, you know, it's having very, very severe impacts because of the experience of coercion. Next slide. There are a lot of patients that are having their voices out there, sort of with real concerns that they're expressing about the policy, so please do look at some of those articles. The BBC Unheard, the unheard.com is particularly important because it's a deep dive journalist with a lot of evidence that hasn't previously been in the public domain. Next slide. I think I'm nearly finished. Right. The Oxfordshire Health Overview Scrutiny Committee has made recommendations to really take this issue nationally, but also to really encourage all local systems to just keep the patient at the centre of decision making. And the whole system really is sort of looking at those recommendations sort of now, which came after quite an extensive scrutiny involving all stakeholders across Oxfordshire, but also involving the South East region, that found that the pregnancy prevention accelerations were unsafe with negative impacts on waiting lists and clinical welfare, and severe concerns about the impact of the processes on all stakeholders. I think, I'm nearly there, I think. Sorry, next slide. You can just look, these are really just for your information. It's important evidence really around epilepsy risk and sudden unexpected death in epilepsy, which isn't well understood. And my final slide really is this recommendation from Embrace in 2020 about the real essential nature of having balanced conversations, you know, if we want to, you know, help keep women and well, it applies to boys and men safe, but this is particularly in relation to sort of maternal mortality. Thank you very much.
Thank you, Jane. Really helpful to hear about the perspective from the patient, because obviously you have that contact with the patients with epilepsy. I think it's not easy, and I'm sure Jane and all are about to discuss some cases which are not straightforward. And I think, you know, on the one hand, we know we've got to adhere to the MHRA alerts and the expectations, but I completely, you know, we have to be very mindful of the fact of not stopping valproate, about considering the patient, and so on. So Jane and Orla, I'm going to hand over to you, please, for the next section. Thank you.
Oh, hello everyone, just Jane Adcock here. Orla, I think I've been put before you, I'm so sorry. I've got 5 quick cases, but I can, somebody can just stop me after 3 if we're running out of time. I just had a number of quick cases just to sort of emphasize some of the difficulties we've got. And it sort of highlights actually a lot of what Jane Hannah's just said about the complexities with the patients. So next slide, please. So I've got a couple of fairly straightforward cases. I've got first one is a young woman who's only 24, but she's got severe learning and physical disability, requires 24-hour care for all activities of daily living, lots of seizures, tried lots of medications, but she's actually very steady currently on the 2 drugs we're talking about, topiramate and valproate. But because she has 24-hour care by her parents, because she could never consent to sexual activity, I was happy, and my second opinion, we were all happy with parents, that we could sign step 1, that she is not at risk of pregnancy over the next 12 months, so she does not need a contraceptive agent. Now, so I think that's a fairly straightforward decision. We felt that was straightforward. But sometimes not everybody agrees with that. Some people have suggested that everybody on these medications, even with this profound disability, should use a contraceptive agent, but we felt in this situation that was not required. I'll go to the next case. And case 2, this is someone we have a lot of patients like this, women in their late 40s, early 50s. Mrs. B has got generalized epilepsy since the age of 10 with tonic-clonic seizures, but has been seizure-free since the age of 18 on sodium valproate. She's never taken any other agent. She does have a contraceptive coil in place, so she fulfills all the criteria in terms of contraception. But the MHRA says other agents should be discussed, should be considered, and she does not want to make any change to medication. She feels very safe, and even the discussions create severe anxiety. So we have signed the form, step 4, because she is using long-term contraception, but technically we cannot sign the steps on the form that says other agents have been tried. We bring her off valproate. So again, not every single step on the form is fully as per MHRA recommendations, but if someone's seizure-free for 30 years, completely understand why they don't want to change medication, and it's a bit easier if they're using contraception. But again, these are quite complex conversations, upsetting conversations for the patient to even discuss the idea of coming off valproate. So virtually no patient is as straightforward as we would like. Next case, and we can come back and discuss a couple of these a bit later at the end. Now, this is someone, this is a difficult situation, and these are all my patients. They're all very recent cases. I've got a 35-year-old lady who is well controlled on valproate and zonisamide, previously had lots of tonic-clonic seizures, tried lots of drugs, and this is the combination that works for her. Now, she's also tried many different types of contraception, not tolerated. So because of that, her husband has had a vasectomy. She's not using any chemical contraception. A vasectomy in the partner is not listed on the MHRA regulations as effective contraception. So technically, she does not fulfill the recommendations because she's physically capable of becoming pregnant by another partner. So we've had to have quite careful and sensitive conversations with her husband present to say, if you get a new partner, then we have to come back to using contraception. And so we have had quite a lot of discussions at consultant level about whether we can sign the ARAF, because technically she's not using contraception, although in reality she is. And so I'm not saying there's an easy answer, but I'm just saying as an example of why these things are never straightforward. And the idea of discussing with a couple that somebody might have a new partner, it's not an easy conversation to have, and can be very upsetting. So again, even the discussions about these things are nerve-wracking for a lot of patients, understandably. Next case. Next, thank you so much. I might just go back one, if I may, back one slide. Sorry, thank you. And this is again a very recent patient, a young woman, has had lots of tonic-clonic seizures from a generalized epilepsy syndrome, tried lots of medications, including valproate, but finally is seizure-free on a combination of topiramate and zonisamide. She had an unplanned pregnancy last year before the new topiramate regulations came in. Now the topiramate regulations are in. She does not want to use contraception because she does not have a partner, even though she's had an unplanned pregnancy. And so we are having ongoing discussions because she's refusing to use contraception because she says, I'm a grown-up woman, I can decide, I know when I want to use contraception, but we've already had an unplanned pregnancy. So we don't have an answer yet. We've been discussing with her and her GP, who's very helpful. He's continued to prescribe topiramate. The risk of changing, of course, has a risk of seizures. So again, another complex case that most of our patients are not easily straightforward and require a lot of discussion in the clinic. And just one last case, very quickly, I may move on. Oh, again, this happens quite a lot. I've got a young woman, again, seizure-free on valproate, failed many other medications. She does not have a partner, not sexually active, very strong religious views about not having sexual activity outside of marriage, and feels very strongly that she does not want to take contraception, that she would choose to use contraception when she gets married and is planning a family. And she's got very firm views and understandable views. And so so technically we can't complete an ARAF because she's not using contraception. There are ongoing discussions about how we manage this. So I've just brought up some of the complex cases, but many of our patients are complex and need a lot of discussion, and there are no easy answers. So I'm going to stop there just to give you a bit of a flavour of the sort of difficulties we're having. Thank you.
Yeah, I think what this demonstrates, Jane, is how individualized these discussions have to be, don't they? You can't have a definite solution for everybody,
No.
and I think that's why this takes time, doesn't it? And I think what's interesting from the discussion that you've just had is actually it's not a final decision on the day you see them.
No.
There's a lot of discussion that happens with your consultant colleagues, with the GP,
Yep.
perhaps.
Yep.
The patient might need to be brought back. So getting these ARAF forms completed. It's not something that happens rapidly necessarily in
No.
these more complex patients. Yeah,
that's correct. And even when we do have a digital form, the time-consuming thing is, of course, the discussion with the patient, which discussions are nuanced, have to be very sensitive, and they're not quick. And so that is, but anything that saves time, of course, with the digital form is always helpful.
Yeah, thank you. Okay, Orla, thank you very much, Jane. Orla, are you here on the call?
Yes, I am here. Hi.
Oh, thank you. Would you like to?
I do have a slide set which I will add to the slide set, which is the one that I presented at the away day. It's the similar kind of themes of what I want to. I can share it actually now, but in fact, Jane, what I really wanted to do was highlight the major issues that we see in both learning disability and mental health, which isn't so much on my slide set. But essentially, one you've brought up there, Jane, thankfully, and it is that issue of consent, particularly in our learning disability cohort. The question of consent to have a sexual relationship is all tied in, and then obviously the question of consent to valproate. So we need to think very carefully and document very carefully that the patient has understood the conversation you're having with them about valproate. Now, part of understanding is being able to go away and have that information in an accessible form and be able to process it. What you'll have heard from Sarah today is that they're making an easy read leaflet, but it's not there yet. There certainly isn't an easy read leaflet for men to be able to explain those risks to them. So we're already on the back foot because we can't easily provide good accessible information to explain this to patients. But then there's that whole issue of, okay, well, you've understood the conversation about valproate and you've understood those risks, but do you understand that whole concept around sexual relationships? And so what you will find is people will make very individual, personalized, which is right, personalized patient care decisions about that patient and their ability to have a sexual relationship. I have a client possibly very similar to yours, Jane, who probably can't consent to a sexual relationship, but she doesn't live with her parents. She lives in a supported accommodation. And so she is on a contraception. And for lots of reasons, we felt that that would be better. I still think if she had a sexual encounter, it probably wouldn't be consensual, but it was felt that she would be better protected, put it that way, on a contraception. And then you've got to have the whole consensual or capacitous conversation about that contraception. So that's one complexity to raise. The other complexity I wanted to raise was that question, and again, I raise it in my slides, which I will just share briefly. It's that question of who does that ARAF, and I see some of the questions have come up there. Who is involved? Who should you send the ARAF to, or the request to the ARAF to? And so broadly, if the patient has the diagnosis of epilepsy, or if the valproate has been used to treat or prevent seizures, broadly, that request should go to neurology. And if the patient has a diagnosis of a psychiatric indication, that request should come to our teams in mental health. Now, you'd think that would be easy, but it's actually super difficult. And I know in primary care that you can have patients, you may find patients who've been on valproate for years and you just don't know who started it or why it's there. And I think in that case, I mean, obviously follow the trail back as far as you can and see which secondary care professional has last been involved and ask them to get involved to do the RF. If you send it to us and we say, look, we're not responsible for the epilepsy, we will let you know and we will pass it on to neurology. Or we're not responsible for the valproate. But sometimes there are patients where it's a bit confusing. And I think in learning disability, it can be especially confusing because in our learning disability teams, we do epilepsy care planning, although we're not responsible for prescribing the valproate. So the neurology will prescribe valproate, we'll do the epilepsy care planning within the mental health team. So that was one of the points I wanted to make. That's complex. And then the final point I wanted to make, sorry, my slides are now not moving. I've made the point about capacity and the information. But again, it's just about being mindful that this whole harm that they're talking about is a risk of learning disability and neurodiversity. And just please be mindful of that when you're speaking to patients who either have learning disability or are neurodiverse. Slightly separate to that question about learning disability, I also want to mention that the information, this study in men is really quite controversial. Part of the issue is that it was the study that compared men on valproate to men on lamotrigine and levetiracetam. So the comparator is not a suitable drug to use in bipolar disorder. So if you're speaking to a man who has bipolar disorder and you're trying to tell him that there's an increased risk because of this study, the study is not technically relevant to his population to him with his illness. And that's tricky. I'm not saying it means it's irrelevant and therefore shouldn't be applied, but it just means if somebody is really interested in the evidence and understanding the evidence, but has bipolar disorder, like the MHRA easy read guide or quick guide, visual aid guide, miswords how it suggests that the man could use these alternative drugs. If he has bipolar disorder, he couldn't. Anyway, I'm going to stop there because I do want to leave time for questions.
Thank you, Orla. I'm just also interested to know about the that link in with your colleagues across in neurology, and because like you said, these are really complex patients sometimes, aren't they? And I'm sure that you have those sort of very open discussions, don't you, around. We do. We also have another particularly complex area, and I think our lovely primary care colleagues will probably find some patients out there. For many years, when we started a drug called clozapine, it was an antipsychotic and it could cause seizures. If we thought there was a high risk of somebody having seizure, the psychiatrist would start valproate. It's not common practice now, but it's possible that there are many patients out there who were initially started valproate for that reason. And in that case, even though it was seizure prevention, it's the psychiatrist that should be doing it, if they were reviewing the men. Now, by and large, you should not be referring men back to psychiatry for a review. You only refer them back if they want to stop the valproate. You don't need an annual form or any kind of any additional forms. If a man has been on valproate for years and he's happy to stay on it and happy to follow the recommendations for his partner to use contraception, etc., they don't need to be referred back into secondary care. It's just on initiation, isn't it? Yeah, but obviously those of childbearing potential, they need an annual review. Females, women, biologically women of childbearing potential. Jane?
Just to add in that, yes, at the moment, women on valproate need an annual review and have an ARAF, but men on valproate, already on valproate, do not need an annual review unless there's a particular issue, and they do not have an ARAF required at present, only on initiation. So the 1,000 men that are out in the community already on valproate that we've just heard about, at the moment, an ARAF is not required. It's only on if we're starting it for the first time. So we don't have to panic that 1,000 men have to come for an annual review at present.
No. And Jane, can you just clarify who can actually sign the ARAFs and the risk acknowledgement form? So the ARAFs for the women and the risk acknowledgement form for the males on the initiation.
So the MHRA states an in-depth, so it'll be usually the consultant who oversees that patient's care in the secondary care, and the second signature is from a second independent specialist. Now that could be another neurologist, it could be an epilepsy specialist nurse. The specialist hasn't been officially defined, so everybody will have their own second specialist. At the JR, we are having a second epilepsy consultant or another neurologist. So we've decided to have consultants being the second signature, but other places, our epilepsy nurses are fantastic, and as they are elsewhere. So some places have their epilepsy specialist nurse as a second co-signature, or we do an MDT, and we actually are doing sort of MDT meetings with at least 2 consultants to make that the second decision.
Okay, thank you.
Can I add? So what it can't be is a GP, and we won't certainly be writing to our GP colleagues to say, hi, could you be my second signatory? And so in our trust, we have equally said we'd prefer a consultant to be that second signatory, but I have done a few. We have pharmacists and nurses, so you won't always get doctor such and such signing. It cannot be a GP, and similarly, a psychiatrist couldn't sign as a second specialist for a neurologist. We won't be writing. So I think it's really interesting. So Janice has has raised a question about what's happening in private practice, and it does appear that in private practice they may be struggling to find second signatories. But I would just add that it's not really the role of the NHS to kind of fill that gap for them. I guess if patients need to be referred into the NHS to have that service fulfilled, they would be referred as would anybody else. But you can't just, you know, pull someone in to do an independent review. It's quite a thing to take that responsibility.
Yeah, I think the private teams need to have their own. They need to have their own setup,
Yeah.
don't we? Just in the last minute, we've got a question, and I think you've answered this, Jane, already, and that's obviously male patients will not have had, if they've been on it for a long time, will not have a risk acknowledgement form in their notes, and they do not need to be referred back, do they? It's only the new patients that are being started from whenever the alert was, you know, from sort of now, that would need that done. Yeah, okay, so that's fine. Okay, we're at 2 o'clock. Thank you.
Can I just, I know we're just on time, but I did have one question come in that I just wanted to answer, because somebody had mentioned they had somebody requesting shared care, but they hadn't provided the ARAF or the RAF. And yes, absolutely, you should expect that with a request for shared care. So if somebody has been initiated on valproate and then you're getting a letter saying, please, can you take over prescribing, you should be getting an ARAF or a RAF from us at the same time.
Great, thanks. And then there was just one final question, the last moment, and that's about it's actually, this is for all indications, isn't it? It is regardless of whether you're on it. I mean, because somebody's written here, what about as mood stabilizers?
Yes.
But it's the same. It's the same MHRA regulations, regardless of clinic, of the actual condition that the patient is. Yeah. Thank you, Jane.
Very quickly, we've talked mainly about secondary care with epilepsy and psychiatric disorders. But topiramate is used in the community as almost like a first-line prophylactic agent for migraine, initiated by general practice. And so those ARAFs are done, usually would need to be done in general practice if they've been prescribed in general practice, because a second signature is not required.
Yeah,
but we've not really touched on how much topiramate is used in the community, not in secondary care. So that's another issue for the general practitioners to keep in mind.
Yep, thank you. Great, thank you, Jane. Thank you all. Thank you all our speakers today, and thank you everyone for attending. We will circulate the slides, and the recording will be made available for those that weren't able to attend. But thank you for your time, and hopefully that's been useful. If there are any other questions, please do send them through to Medicines Optimisation inbox, and we'll see if we can try and sort those out for you as well. If there's anything you think about afterwards. Take care, everyone. Have a good rest of the afternoon. Bye now. Bye.
Thank you, everybody. Thank you, Jane.
Thank you very much.